Good evening, everyone. I welcome you all on Surgical Insight by Dr. SRB, sir. Good evening, sir. Today we have joined here for today's our first live case discussion that is on the case of swelling under mentorship of Dr. SRB, sir. As sir has told during one-on-one live session that sir will be arranging a live case-based discussion. So sir is here with it. So today sir has selected two candidates. The both are from third year postgraduate MBBS student, Mr. Karthik GK, who is from KIMS Madikeri, and Mr. Keshav from Sri Venkateshwara Medical College, Pondicherry. So, sir is, we all know, no need to introduce sir, a well-known author of SRB Manual of Surgery, SRB Clinical Textbook of Surgery, and today we are again here with sir live with this session. So now, without wasting much of time, I'll hand over Karthik to start the session.
Karthik, start. Shreya, slideshow.
Over to you, sir.
We'll discuss exams and swelling. Shreya will. Karthik, start.
Yes, sir. So the clinical history goes like this. A 46-year-old patient named Miss X, who is a farmer by occupation, hailing from Ariyur, Tamil Nadu, who came with chief complaints of swelling over the left upper part of the back for past 6 months. Next slide. History of presenting illness goes like the patient was apparently normal 6 months ago, after which a swelling was noticed over the back by her daughter, which was insidious in onset, progressive in nature, and initially was small in size and gradually attained a size of 4 cm cross 6 cm in dimension. She had no history of fever, trauma, other swelling anywhere in her body, loss of weight and appetite, and also no limitation of movements. Past history goes like she has no history of similar complaints in the past, no history of hypertension, diabetes, epilepsy, asthma, and tuberculosis, no history of previous surgery. In her personal history, she consumed mixed type of diet. She is not an alcoholic or smoker. Her bowel and bladder movements are regular and has adequate sleep. Family history, she has no history of similar condition in her family. At the summary, we get that a 46-year-old patient comes with the chief complaints of swelling in her left upper back for past 6 months, which is gradually progressive and has attained for current size of 4 centimeter into 6 centimeter, which was previously smaller in size, and she has no history of fever, trauma, other swelling in her body, loss of weight and appetite, and limitation of movements.
Okay. Karthik, we'll just have discussion 1 minute. Shreya, go back to the history. We'll have to discuss the history. Go back to the first slide. Right here, we'll start from here. History of present illness, you have told everything, time, duration, progressive nature, rapid onset you didn't mention, recent increase in size you should have mentioned. And
Yes.
thing is, in the history, you don't require to mention the size because patient is telling her or his own lucid language. They won't be bothered about the size. They will tell current size. Put it like attained current size. Dimensions not necessary. Sometimes they'll say size of apple, size of this cricket ball, size of small ball like that. That will, may take it as a kind of approximate size. But usually current size or whatever the dimension can tell, you need not give the exact measurement. Then other things, other swellings in the body. You said loss of weight, loss of weight. What's the significance of asking that question? Loss of weight and loss
Sir,
of weight.
Sir, loss of weight is mainly seen in malignancy, sir.
Right, but
Malignancy.
every surface malignancy will cause a loss of weight, loss of appetite.
No, sir.
So which surface malignancy will cause when it will cause a loss of weight, loss of appetite? Suppose surface malignancy is there, maybe squamous cell carcinoma, maybe sarcoma, whatever it is. Suppose if you think that particular swelling is malignancy, then if patient is having loss of appetite, loss of weight, so what it suggests for you? You have understood my question. Is it clear? Karthik?
Yes, sir. Yes, sir.
what it suggests for
Like
you.
we can say that advanced stages we can tell about that, sir.
But if any surface malignancies, usually they don't, like carcinoma breast, sarcoma in the surface,
Mm.
will not have a loss of weight, but unless they are metastatic, unless they have visceral spread. What we think
Yes, sir.
usually is such a situation, probably patient is having metastatic disease, specifically visceral spread. Then limitation of movement, you have told that is important when it is close to the joint, especially this area, absolutely right, because in the deeper plane, you got a scapula. If it has gone into the scapula, they will have a limitation of shoulder movement because scapula will prevent that movement. Next slide, Shreya. Right, past history, you mentioned whatever the things. Why history of previous surgery is important for you?
Sir, if there is a before history of lipoma and there is a remnant, sir, it can regrow, na, sir.
Okay. Personal history is a routine for management purpose. Now your family history, look at that family history. That is not detailed, is not sufficient. You better to ask how many siblings patient is having, how many children they are having, and family tree it is called as, and how many siblings parents are having. At least 3 generation family history should be asked. Or family tree, if you draw, that is better. Or at least how many
Yes,
siblings, whether siblings are anybody having. There are so many swellings run in family. Can you tell us few conditions which run in family?
like
Swelling.
sir, Durkan's
No.
conditions, Durkan's disease, like and neurofibromatosis, sir. They will run in families.
And lipomatosis, neurofibromatosis,
Yes,
lipomatosis, multiple seepage system, sometimes in some syndrome with that, so can run in the family.
yes,
Specifically, at your level, if you look at the neurofibromatosis may run in family, then they will have
yes,
multiple swellings, and the family history they'll say some family members also having. So family tree to get the what there is very important. Okay, so next let's say.
yes.
So summary here briefed very nicely. So it is many times in the exam, examiners expect to write a summary of the history and a summary at the end of the examination. So some examiners expect to write summary at the end only, but it is better to split and we'll have the some idea. So based on this, what you think spelling could be just by history. You are not examined. Whatever you are thinking may be only basic analysis, not the final assessment at all because you have not finished the exam. So at this juncture, what spellings could be this one? What all possibility you will think of by
Sir,
history?
we can think of lipoma, sir, and we can also think of
Okay.
sebaceous cysts.
Sebaceous cyst and lipoma, we can think of. We can think
Yes,
of
sir.
hereditary neurofibroma also. So we can. You
Yes,
want to
sir.
think of
No,
dermoid? Will you think of dermoid in this patient? Will you
no,
think of?
sir, because it is present along the lines of fusion of
Right,
embryonic
absolutely,
glands.
absolutely. Not in the line of fusion. So you think of three conditions, that means common conditions. Lipoma, definitely, right? Then sebaceous cyst you have to think of because not to examine, and
Yes,
neurofibroma, definitely possibility, solitary possibility is there. So these three conditions you have to keep in mind by taking the history. So
yes,
next slide, Shreya, we'll go for examination. Karthik, you have presented well, but history, that details is important. Still more detail history taking writing is important, especially family history and here and there additional history depending on the location of the swelling as such. So we'll go on to the general examination. Probably Keshav is presenting, no?
Yes, sir.
Keshav, over to Keshav. Keshav, put on your camera,
Yes, sir.
okay, and start presenting.
Next slide, ma'am. General examination slide. After that, ma'am. Ma'am, next slide. Yes, ma'am. General examination. The patient is conscious, cooperative, and oriented to time, place, and person, well built and nourished. There is no pallor, icterus, cyanosis, and clubbing, lymphadenopathy, and edema. Pulse rate is 18 beats per minute, and BP is 126 by 80 mmHg. Respiratory rate is 18 cycles per minute, and temperature is afebrile. Next slide, ma'am. Next slide. Okay. Edge is well defined, regular. The surface is smooth. Skin over the swelling is normal. The surrounding area is also normal. There is no presence of punctum, no pulsations are seen, no scars, and sinus and dilated veins. On palpation, they are not, it's not warm and tender. The surface is just previous slide, ma'am. Ma'am, previous slide. On local examination of the swelling, after getting a consent from the, excuse me, ma'am, actually previous slide. Hello.
Shreyas, now it is in the general examination or local examination, Keshav?
Local examination, sir. Local examination, sir.
Now you can
Actually,
see.
general examination, I didn't. Yes, sir. Now it's in local examination.
You are not, it's not visible to you, is it?
Yes, sir. It's not visible. Only local examination inspection is visible to me, sir.
Okay, you want next slide now.
Previous slide, sir. Actually, a previous slide only I've just elicited the edges and the things.
Shreya, he wants the previous slide. Probably his slide is not moving. Now you can see.
No, sir. Actually, it's cutting in the local examination of the swelling only, sir.
Inspection is there. Inspection.
I said inspection is there.
Okay. Next, you want next slide.
No, the previous slide I didn't elicit the edges and the there is no presence of pulsation. I think, sir.
Okay.
This one, sir.
Okay. Previous slide, sir. On inspection, I'll just start, sir. From inspection, I'll start.
Okay, go back, Shreya. One more. Okay, now it is visible.
Yes, sir. Now it's visible, sir.
Okay, continue.
The edge is well defined, regular. The surface is smooth. The skin over the swelling is normal. Surrounding area is also normal. There is no presence of punctum, no pulsation seen, no scars, sinus, or dilated veins. On palpation, it's not warm and tender. The surface is lobulated, soft in consistency. So, sir, actually,
Hello, Keshav.
yes, sir. I can hear you, sir. Hello.
Yeah,
Sir,
Keshav.
Yes, sir. Actually, ma'am is going for the previous slide, sir. Actually, I'm reading palpation slide.
Next slide. Now it is okay.
No, sir. Still it's in the inspection, sir.
Here we can see the next slide. I guess in your mobile you are not able to see.
It's a network problem with that, I think, Keshav. We can see the movement of. Now you can see.
It is visible.
No, sir. Actually, still, just can please forward the slide, sir. 1 minute.
Keshav, probably you are having a network problem, Keshav.
Yes, I think so. Actually, there is some climatic issues here also, sir.
Okay, you now you can see what you can see. Palpation you can see.
No, sir. Only inspection, sir. I'll read palpation, sir. I have the notes. I'll read the palpation, sir.
Okay, you present, no problem. Okay.
Okay. There is no local rise of temperature in the tenderness. There is a swelling in the right side of the. Just a minute. Just a minute. Now I can see the palpation, sir. It's not warm and tender. The surface is lobulated, soft in consistency. The skin over the swelling is pinchable. Plane of the swelling is subcutaneous. The mobility is freely mobile in all directions. The slip sign is positive. Fluctuation cannot be elicited. And trans elimination test is negative. It's not compressible, reducible, not pulsatile. Next slide, ma'am. Next slide. Now I can see the palpation, ma'am. Okay. This is other systemic examination is showing, sir. Yes, sir. On examining the respiratory system, normal breath sounds are heard. No additional breath sounds are heard. On CVS, S1 and S2 sound is heard. No additional sounds are heard. In CNS, sensory and motor systems are normal. On examining the abdomen, soft with no organomegaly. Next slide, ma'am. Summary of the slide. Next slide.
We are on the summary.
Yes, sir. Okay, sir. A 46-year-old patient comes with a chief complaint of swelling over the left upper back for the past 6 months, which is insidious in onset and gradually progressive in nature. The swelling is small in size and gradually attained 4 cross 6 centimeter. Her vitals are normal. On inspecting the swelling, which is 7 cross 7 centimeter, is seen on the left scapular region. The inspection findings are confirmed on palpation. There is no local rise in temperature or tenderness.
Yeah,
The swelling is lying.
Okay. Continue.
Yes, sir. The swelling is lying in the subcutaneous plane, which is soft in consistency, feels freely mobile in all directions, and slip sign is positive. Fluctuation cannot be elicited. The swelling is not compressible, reducible. No lymph nodes are palpable.
Share next one. Okay. Okay.
Provisional diagnosis.
Back, Shreya, back. Okay. Wait, Keshav, we'll have a discussion.
Yes, sir.
Go back to summary, Shreya. Go back to summary. Okay. History is important while taking, because you need to take consent, you have mentioned. But another thing which is important is,
yes, sir.
Privacy should be during examination. Privacy is important. So consent taking also
yes,
important.
Sir.
It may be usually written consent is not taken in our setup. Maybe in Western setup they may do that. Usually it is a oral consent. Once you have come to you for examination, it is understood that they have given consent. But privacy should be always maintained while examining the patient, whether it's male or female patient.
Okay,
point which is important. Then second thing you said, mobile. Is it mobile freely or not, Keshav? Louder. I can't hear you.
It's freely mobile, sir.
It's freely mobile.
Yes,
not,
sir.
It is not fixed to the deeper structures.
No, sir. It's not fixed to deeper structures, sir.
Which muscle comes underneath this swelling? Have you checked the mobility of the
swelling?
Have you checked the mobility of the scapula while moving the shoulder and checked whether what happened to the swelling? Because this is over the scapula, over the outer surface of the scapula.
Yes, sir. Yes, sir.
Have you checked the mobility of the scapula and checked what exactly happened to swelling? Whether it moves.
No, sir, I didn't check for the mobility of the scapula. No, sir, I didn't check for the mobility of the scapula, sir.
Yeah, that is because that is important here, and you have to know what muscle is there in the deeper plane, and you have to check the mobility. Probably posteriorly here, rhomboid, although so many muscles are there attached to this. So shoulder movement, if you do, if you do a movement like this shoulder, so scapula moves in the arc. And so that's important. So while moving the scapula, what happened to swelling is very, very important. Skin, you said skin is free, no? Skin, you said skin is free.
Skin is pinchable, sir. Skin is pinchable.
Edge, margin, border, all are same in swelling, unlike in ulcer. It is considered the same. Usually margin or border,
yes,
border which you will use. You have to use well-defined and regular, or well-defined irregular. It is well-defined and regular or well-defined and irregular edge of the swelling.
Edge of the swelling is well-defined, sir. Well-defined. I didn't mention regular or irregular. I just mentioned only well-defined.
This is well-defined and regular. And if it is well-defined and irregular, what condition comes in your mind?
Any kind of inflammatory swelling, sir.
Well-defined and irregular, we'll think of neoplastic condition, especially malignancy.
Yes, sir.
Ill-defined, what condition comes in your mind?
Ill-defined condition.
Because in the edge you have to use defined irregular, ill-defined irregular. Like that, these terminology you have to use always to take health. So if it is ill-defined, what condition comes to your mind?
Ill-defined.
Either a diffuse entity like diffuse lipoma, or a swelling which is in the deeper plane, or inflammatory conditions.
Okay.
Inflammatory conditions in the initial
I
phase
see.
will be ill-defined and diffuse. So the moment it is diffuse, ill-defined, conditions which are ill-defined, we should come into your mind to offer a diagnosis. Understood? So that's why this border is very important. Whether it's well local swelling, whether it's protruded or not, all those things are important. What is the meaning of swelling
Okay.
in clinical side? In a clinical side, if somebody says in surgical clinical side, if somebody says swelling, what is the meaning?
Yes.
What exactly meaning?
It's just a uh, protrusion of a sac.
Right. It is the
Can you hear me, sir? Hello.
protrusion of the part of the.
Yes, sir. Enlargement or protuberance in the body due to any cause.
Yeah, that's why even though it
Enlargement
is
or
protrusion, even though it is protrusion,
yes, sir.
whatever it is arising from will not alter its whatever organ or alter its normal nature. Understood? Like surface swellings, it is called
Yes.
swelling. How it different from the lump? Where will use the word lump?
Lump is a vague mass of the body tissue, sir.
It need not be vague mass. Lump is arising from the organ, and organ, it's within the organ, and organ organ of organs texture will be altered. So that's why it is called as lump, like breast lump. It is within the breast lump. So breast lump
Yes, sir. Breast lump.
may be altered. You don't sell even you don't call it usually as a breast swelling. And when you use a mass, all are
Mass,
same actually.
which
Swelling.
is
In specific areas, we use clinically specific nomenclatures. Swelling in the surface area, breast will use lump, and mass in certain areas. Where will use mass? Word mass in clinical, especially in surgery, where will use mass?
multiple
So,
swelling, sir, in case of mass.
No, that is
In
not
case of
much.
neoplasms.
involving
No.
deeper organs.
Yeah, no, deeper organ means how deeper organ, Karthik? Karthik, you can also join for answering, no problem. How deeper organ? Keshav?
Sir, deep, if it's like subfacial or periosteal like that, sir.
Yeah, no, in the abdomen, mass abdomen will say, because we won't be able to define the swelling properly in mass abdomen. So that's why it is called as mass, abdomen mass, breast lump, surface swelling. This is the nomenclature, even though all are similar, but the nomenclatures are clinically very specific. It have a specific meaning. That's why I want you to understand these different meanings. Then fluctuation is said.
Oh,
You said it is not fluctuant, no?
yes, sir.
What
It
is
is semi-fluctuant also, sir, sometimes.
what is the meaning of fluctuation? What is the
Fluctuation actually, while touching the edge of the swelling, it slips off, sir.
okay? No, that's a clip sign. What is the meaning of fluctuation? When you will elicit fluctuation,
Fluctuation.
what is the method of fluctuation?
Actually, whether in the swelling, whether the liquid or gas is present in the swelling, it is said to be fluctuant, sir.
Okay, that's right. Liquid, mainly fluid nature. It says content of the, that content of a swelling can be solid, content of swelling can be liquid, content of swelling can be gas. Okay. Commonly, what we consider
Yes.
other than hernia, it is a solid or liquid. Now, solid will not alter the shape, will not alter the volume, whereas liquid will not alter the volume, may alter the shape. So that is why this liquid is assessed by fluctuation test. So how exactly you will do the fluctuation test? How you will
It should be carried out by one finger on each hand, sir.
okay,
Sudden pressure is applied on the one pole of the swelling, sir. This will
okay,
increase the pressure within the cavity of the swelling and will be transmitted equally at the right angle to all the parts of the wall.
okay. That's you have to do in the two direction perpendicular to each other. That's important. And what is
Yes,
the
sir.
prerequisite to elicit fluctuation? Karthik, what is the prerequisite to elicit the fluctuation? In any
Sir,
swelling when you elicit the fluctuation.
sir, it should be like contents, liquid or gas.
And that's what you are. Once you do, only you will know that it is. Will know that it is a fluid. So prerequisite
Yes,
is you have to fix the swelling. You should be able to fix the swelling. If you won't
yes,
be
sir.
able to fix the swelling, you cannot elicit the fluctuation. So in abdomen mass, You can't fix the swelling, so cannot elicit the fluctuation. So only mainly the surface swelling will be able to elicit that. So you have to always fix the swelling, then always elicit the fluid movement in two direction according to
Yes,
the
sir.
Pascal's law. So law used is here Pascal's law. So in two direction you have to elicit the fluid movement. Unless you elicit movement in the two direction, it is cannot be called as fluctuant swelling. Cannot say that the content is fluid. Understood? So what is so you know now that you have to fix the swelling. You know now that you have to elicit the fluctuation in the two direction like this, like this,
Yes.
like this, and so to say it is fluctuant. And so what is the meaning of cross fluctuation? What is the meaning of cross fluctuation? What it crosses? What is heard about cross fluctuation? Keshav?
No, sir.
No, you've not heard about cross fluctuation. So cross fluctuation is the
No,
one
sir. Actually,
which differs from the fluctuation. It is fluctuation across an anatomical barrier. Can you give some example from one area to other across an anatomical barrier? So, for example, compound palmar ganglion, ranula, or psoas abscess, different areas, bilocular hydrocele. Because in across, so psoas abscess across inguinal ligament, compound palmar ganglion across flexor retinaculum. So across an anatomical barrier, you should be able to elicit fluid movement. Then it is called as cross fluctuations. It's a totally different entity. It is not the standard fluctuation. Standard fluctuation should be elicited. We should be able to elicit in two direction perpendicular to each other. Now, only one direction, if you elicit fluctuation, what it is called as?
So pseudo fluctuations.
That is called a
fluctuation.
fluctuation, which a normal organ is a pseudo fluctuant. Normal tissue. Which normal tissue is pseudo fluctuant. Skeletal muscles are pseudo fluctuant because you won't be able to sit on two sides. Okay. Then lipoma is fluctuant, not fluctuant. What is false fluctuation?
They are semi-fluctuant, sir.
No.
Semi-fluctuant. Pseudo fluctuant.
Semi-fluctuation, there is a because it fat contents may be elicited. It's actually it is properly should be called as false sense of fluctuation. Even though many times we call it
Yes, sir.
fluctuant, ideal terminology should be used. It is false sense of fluctuation. You feel like it is fluctuant, actually it is not fluctuant. Actually, it doesn't contain fluid. This is what exactly its meaning. So
Yes,
lipoma has got false sense of fluctuation, not a true fluctuant swelling as such. So once you do the fluctuation, always you have to do the, if it is positive, you have to do the transillumination. How exactly you will do the transillumination? Keshav?
We have to, yes, sir. We have to keep, we have to roll a paper on the one side, sir, and we have to keep a
X-rays.
torch on the other side, sir.
Okay, you have to
We
eliminate
have to keep a torch on the other side, sir.
eliminate that pen torch, ideally covered with the black thing, and with the transilluminoscope,
Yes, sir.
you see the illumination. Which all swellings
Yes, sir.
in the body are called all brilliantly transluminant. If swelling is
Sir,
transluminant,
ranula, sir.
ranula, okay.
Sir, hydrocele.
Hydrocele, hemangioma,
What?
hydrocele, sir.
Hydrocele, okay. Many hydroceles are brilliantly transluminant, agreed. Any other swelling which are
Hemangioma, sir.
hemangioma is not transluminant. It contains blood. No, how it will be transluminant? No.
Sir, ranula, sir.
Ranula, you said already accepted. Ranula, hydrocele, somebody told. Any other swelling? Meningocele is transluminant brilliantly. Epididymal cyst is a transluminant. Heard about epididymal cyst?
Yes, sir.
The scrotum.
Yes.
So that is a typical Chinese lantern pattern. It is. So these are
Yes.
the swellings which are brilliantly transluminant. So once a swelling is a transluminant, what it suggests? What it suggests?
Sir, it is filled with serous fluid, sir, clear fluid.
Clear fluid. So immediately says that it's clear fluid. So all conditions, all swellings which pathologically contains unclear fluid are ruled
Yes,
out. So you got, if it is transluminant, you got certain conditions only in hand. So all other conditions are ruled out. So it's very important. So if fluctuation is positive, it is your business to do next immediately is translation to find out the nature of the fluid. Fluctuation says it is fluid or not. Then after that, you have to find out whether it's nature of the fluid, clear or unclear. So clear, you will be able to say if it is transluminant. So you have to remember which all swellings are transluminant. Then you said pulsatility. What is that pulsation you meant?
Yes, sir. In case of aneurysm, we can able to feel the pulsatility, sir. If
Yeah.
there is any
What are the two types of pulsations you know of?
expansible pulsations
Okay, expansile and
and transmittable pulsations, sir.
give some examples of expansile pulsation. What is the exact meaning of expansile pulsation? How will
Sir, actually, yes, when two fingers actually keeping a two fingers, it's not raised but separated with
okay,
each
separated
artery means
is
it's
right.
expansile pulses.
Absolutely right. You put the finger over the swelling. If it is raised and separated apart, that is the term used. Raised and separated apart,
Yes,
that
sir.
is the expansile pulsation, like aneurysms. What is the meaning of
Yes.
transmitted pulsation?
Yes, sir. When we keep the two fingers only raised but not
Only
separated.
raised but not separated. Only raised but not separated. That is called transmitted pulsation. So give examples of transmitted pulsation. Can you give some examples of transmitted pulsation in the body? Common condition.
Sir, aneurysms like in
Pulse.
radial artery.
No, aneurysms are having, or traditional hemorrhage has got a expansile pulsation. Pseudocyst of the pancreas,
Pulsatile swelling of the abdomen, sir.
abdomen, pseudocyst of the pancreas has got transmitted pulsation. Okay,
Yes.
but here in the abdomen, you cannot use the finger test to elicit, find out whether it is expansile or transmitted pulsation. So you have to check the pulsation. You change the position of the patient, then see pulsation is same or not, intensity. Or olden days, we used to put the patient in the knee elbow position. Now currently it is not practicable. In knee elbow position or change in the position, intensity of the pulsation is same. That means it is the expansile pulsation, probably aortic aneurysm, abdominal. If it is intensity is not same, intensity is reduced, that means probably it is transmitted pulsation. Commonest condition in the abdomen is pseudocyst of the pancreas. So this is what you have to remember. Abdomen fingers are not used for to elicit pulsation, expansile or transmitted pulsation. Change of the position or knee elbow position, at least in olden days. So there is a point which you have to remember. He already told plane. Plane is important, whether the skin, subcutaneous plane, muscles, intramuscular or facial plane, or from the bone. So they got different features to say that. So I hope most of the people know that. So that is important plane. Freely mobile, he has told already. Slip sign, what is the typical slip sign means what?
Yes, sir. Slip sign. Actually, in case of slip sign, when we pressing the
Press the edge of the swelling, it is as if it gets clipped off. So that is the meaning. So palpation,
yes, sir.
say surface next to tell is consistency. Always you should go order. Here, most of the things he has written in orderly fashion. No debate on that. But remember, all students, your presentation should be in the order, especially in inspection and palpation. Surface, consistency. Fluctuation, non-translucent. You can't say translumination first, then fluctuation. You can't say after fluctuation you tell surface, then somewhere you tell in the corner you tell translumination. There's an orderly fashion. Same order has to be followed while writing the case sheet and while presenting the case in the especially in the examination, even otherwise. Okay, exam it is very very relevant and important. So yeah, this is
Yes.
the discussion. So you have to remember all these things. Discussion will come here. Scapular movement is important. What structure is there in the deeper plane? What muscle is there in the deeper plane? Also very very relevant. It's why surgical anatomy deeper to the swelling is very, what structures are there and what is the relation to elicit to that swelling is very very important clinically when you examine the patient. So next slide will go Shreya. So what is the final diagnosis, Keshav?
Final, the suggested diagnosis is lipoma, sir.
Okay, he said the left scapular region, probably lipoma. Why you said lipoma? Why can't it be sebaceous cyst?
No, sir, there is no presence of punctum, sir.
Punctum is
And
not
slip sign is positive, sir.
every patient.
Sir?
Is punctum is necessary to be present in every sebaceous cyst?
No, sir. No, sir.
That's what around 70% of individuals will be there, 30 or more than 30% of patient punctum may not be there. So if it is not there, you cannot rule out. So what is the difference, clinical differentiating feature? Punctum, if it is there, 100%. If it is not there, you can't say it is not sebaceous cyst. So what is the clinical feature?
Sir, any history of
No,
discharge, sir?
history will not be there. Discharge may not be there. It's only later period. Skin, it is sebaceous cyst skin is adherent. whereas lipoma skin is free, pinchable. You have written no, skin is not
It's
pinchable.
test.
It is adherent. It's a cutaneous
Yes.
swelling extending into the subcutaneous region and becomes subcutaneous eventually. Whereas lipoma is usually subcutaneous, skin is free, and lobular surface you have mentioned somewhere, and smooth, lobular, and soft in consistency with the slip sign positive with the well-defined regular edge. So that is the features of lipoma, and usually it is mobile in two direction. But still, you have to remember sebaceous cyst here. You have to remember neurofibroma as a differential diagnosis. There are so many other conditions which will be asked in the exam, but lipoma is a common thing. What is lipoma? What is lipoma?
Lipoma is soft benign tumor, sir.
Benign tumor arising from
Arising from common sites or nape of neck. Here
no,
it's scapular region, sir.
arising from which tissue?
Sir, subcutaneous fat, sir.
No, any fat. Lipoma
Subcutaneous pain.
in the body, arising from yellow fat. It's not
Yellow
just
fats.
subcutaneous. It can be intra-abdominal, it can be intrathoracic, it can be intracranial, it can be anywhere in the intestine. It can occur. It can be intra-articular. It can be intramuscular, submuscular. Anywhere it can occur, except in the probably in the brain. Okay, intracranial it can occur. Some places of the brain it may not occur. So that's why it's called as commonest benign tumor. It is, and it's called as a universal tumor. It's called as a ubiquitous tumor. So
Yes, sir.
understood. So what are the complications of lipoma?
Calcification, myxomatous changes, sir. Saponification,
Okay.
any infection or ulcer formation also takes place, sir.
Those things can occur.
And,
Remember, yes, Karthik.
sir, in thigh and back, we can expect, sir, the sarcomatous
No,
change can occur.
it is currently
Rarely.
that there is no
Liposarcoma, sir.
liposarcoma will not occur in a pre-existing lipoma. Liposarcoma is an independent de novo disease. There is no precursor cell
Yes,
in lipoma to convert into liposarcoma. That is disproved. Lipoma will not turn into liposarcoma. Understood? That's not a complication. Remember, don't tell that. Tell it is not a precursor cell. It will not turn into. So you need to remember need to remember the differential diagnosis. Whatever I have told, you can put that one sentence, even though it is most probably lipoma. So what investigations? What investigations?
Investigations, routine investigation is complete pet count, sir. On specific investigation, FNAC have to be done, sir.
Yeah, first to do imaging. What imaging you want to do here?
Imagine X-ray.
X-ray. What you want to look for? Because these institutes won't be able to see in X-ray. Simple investigation. You can do ultrasound of that area. They'll be able to tell. If still doubt is there, do an MRI. Of course, FNAC, you conclude your diagnosis. So either ultrasound or MRI, X-ray were not helpful here, and FNAC definitely concludes. But it's a benign disease, straight away you can go for surgery. But currently, imaging is the protocol as such. So ultrasound or MRI and FNAC. So treatment you already told excision biopsy. Now, if it is very large, what anesthesia will use? If it is very large, what anesthesia will use? Simple. If you very large lipoma, you have to use general anesthesia. Okay. If it is part of the body, spinal anesthesia may not be able to infiltrate adequate local anesthesia and do the procedure, even though many times we do that. But ideally, large lipoma, general anesthesia or spinal anesthesia in the lower part, or otherwise something like this, definitely local anesthesia is sufficient. What local anesthetic agent you will use? What local anesthetic agent you will use? What block it is called as?
Segmental.
What local anesthetic agent you will use? It is xylocaine. Xylocaine, 2% you will inject, make it 1% and then dilute with the normal saline. Then give field block like this. We can give field block like this around, and then make what incision will make, elliptical or site incision? In lipoma?
Elliptical, sir.
No.
Elliptical is in this one, sir. Sebaceous. Sebaceous.
You do elliptical incision. That skin,
Yes, sir.
skin you have to remove, or punctum you have to remove. Always
Yes, sir.
elliptical sebaceous here. Straight incision over the summit, longitudinal incision will make. Then dissect, raise the flap and dissect and remove the entire lipoma. It's important to remove the entire lipoma. Okay.
Yes.
Otherwise, lipoma may recur. Otherwise, recurrence is less common, and most of the time, result is very good once you remove the lipoma. So remember, it won't turn into liposarcoma. Remember complications. Remember differential diagnosis. Remember local anesthetic agent. You have to remember Dilucan 2%. You can dilute, make it 1%. Field block anesthesia. Large one you have to give general anesthesia. That's the point you have to remember. So that is about things. So presentation is important. History taking is important. Writing diagnose orderly fashion to write investigation treatment. So your entire case should include everything in a long case or any cases in the exam. Write always investigation diagnosis and treatment part so that you can always tell the examiner that I have written the treatment, but proper treatment, and possibly try to draw a diagram of this lesion always. Give
Yes.
the more
Okay.
Okay,
proper
sir.
case sheet. Okay, so always thyroid, breast lump, surface lump, or mass abdomen, anywhere. Try to draw a diagram. That is very crucial and important. That will give the more mark to the case sheet. Always do a complete case sheet. That's important. Never write short forms. That is also important. Okay, so
Yes.
that is the about lipoma. Shreya, next slide. So, so Keshav, you presented well, both Karthik and Keshav. You presented very well. This is a very common short case, remember. All over, anywhere, any college, this is a common short case. So, exams swelling is very important. Differential diagnosis also, remember, he said rightly, he told dermatitis, it is not possible, it's not in the midline. So, use, elicit proper findings, and you do some analysis, clinical thinking, and do decision making, then give a clinical diagnosis, then have a evaluation, final diagnosis, then of course basic treatment pattern aspect,
Yes.
and little bit about that
Yes.
condition, that is also important. Okay, like lipoma, some questions will ask what is hibernoma, what are other causes, what are the other types, all those things. So you can go through the theory, and other swellings also they may ask, they may sometimes deviate your question. They will ask, tell everything about sebaceous cyst, tell everything dermoid cyst, what are the other types of dermoids, what are the tubulodermoids. So all those questions when they ask, you should tell something about neurofibroma, neurolemoma. So deviation of the question, give yellow you should able to answer it. That needs a basic knowledge about individual these topic common topics. Should have a clear idea about all this individual spelling, individual different spellings. Okay. So otherwise, I think Divya, they presented well. Initial some hurdle with the
Yes,
case
sir.
slide presentation. Otherwise, presented both of them well. It's a good full mark to them. Of course, corrections I've already told in history taking other things. So questions we'll have in the chat box. Keshav, Karthik, you have presented well. I told what are
Yes.
the mistakes, everything definitely will improve. You will correct, you will do those corrections. Otherwise, good, definitely very good. So I will have a brief. Yeah,
Yes, sir. Thank you, Karthik and Kesav, for good presentation under the mentorship of sir. So now I would like to request sir to give a brief explanation of swelling. Now, according to you, sir. Over to you, sir.
thank you, Divya, and everybody. Karthik, Keshav presented very well.
Thank you, sir.
On
Thank you,
online
sir.
connecting with the who are seeing this one online somewhere else. So it's very good. So I'll just brief how exactly basic required to examine the spelling. Shreya, next one. So history being put in the chart actually can everybody can see, I think, age, sex,
Yes.
address, occupation, history are present in like don't write short form. That is not allowed in the exam at least. HOPA, all those short forms, TB,
Yes, sir.
DM, all those things. That is annoys the examiner. Don't write. Try to make everything full form. Swelling, duration, mode of onset, site of origin. This very important. Last swelling, you ask where is the origin. That will go to probably anatomical location, beginning of the swelling. You'll have the idea what exactly probability is. Size, they don't require to ask about the dimension. Sometimes they will tell, but they will say the size of lemon, size of apple, size of watermelon.
Yes.
Like that, they will tell. So use those words rather than specific size. So that won't be bothered. And theme is very important. Type, nature, character, uh, radiation, reference, severity. All those types are there. But burning type, type, throbbing type occurs in abscess, like that in inflammatory conditions, different types. Whether subside again comes persistence, intermittent, all the details should be asked. History of fever, commonly it is inflammatory. Sometimes some neoplastic condition, large sarcomas, they will have fever, especially when there is a tumor necrosis. So other lumps, multiple neurofibroma, multiple lipomatosis, multiple divisions are common. Secondaries in the skin, in the primary somewhere, especially in the GA, can have multiple secondaries. Pressure symptoms, especially surface swelling, can compress over the vessel.
Yes.
That's why distal pulse, proximal pulse, in a limb, in a lower limb, suppose dorsal pedis, you have to check. If there is swelling in the upper limb, radial pulse, you have to check. Same thing, edema, you have to check. Venous edema, maybe compressing on the major vein, femoral vein, brachial vein.
Yes, sir.
So those
Yes,
things
sir.
are going to be checked. Loss of function, loss of weight, I said significance already. Past histories again, tuberculosis, diabetes, hypertension, asthma, thyroid disease. Remember, basically 30 to 40% of females will have some sort of thyroid disease, especially subclinical hypothyroidism. But when you treat this
Yes.
patient for some other condition, this will be corrected. So that history, sometimes they'll be taking thyroxine, you will not be knowing at all. So last, sometimes they'll tell after admission, during surgery, they'll tell I'm taking thyroxine. So better to take proper history. Anticoagulant. Now currently, because many patients, especially after 40, they're taking ecosprin, clopidogrel, very common now. Better to specifically
Yes.
ask, are you taking blood thinner? Because if it is so, you have to stop those drugs for 5 days, then only you have to operate. So because so commonly people are taking ecosprin, so better to take specifically whether you're taking or not. That's why drug intake is important. Periodicity of surgery, scar, how long they were admitted, what biopsy report if it is there, and whether there's any wound complication. So detailed history or take. Personal history is important for healing or giving anesthesia. Smoking, alcohol, diet also important. Drug habits. Diet gives it to nutrition aspect. How
Yes.
good nutrition patient is having. Drug habits is also important. Family history, family tree is very important. I already how many children, how many siblings. So how many parents are there? How they had any disease? How parents have died? So those things are very important. That's why family tree is relevant, not just telling that all are all right. No family members have any disease. It's not sufficient. Little more detailed family history is important. Of course, summary of the history is
Yes, sir.
shown. That is important. General examination. Uh, See, do not write short forms. This is already Karthik has presented, because Keshav has presented well. He has written everything. The short forms are not allowed. Pickle, that is everything is very commonly now written in all short forms. It is not allowed in the exam. Next slide, Shreya. So, question palpation. I said already after consent with the privacy. So swelling, I already mentioned everything. Margin, ill-defined, well-defined edge, mobility, pulsation, expansal pulse. You know the expansal pulse? What is expansal pulsation means? Keshav?
Yes, sir.
Expansal pulsation means expansal impulse on cuffing means what? Expansal impulse on cuffing. How will you define it?
Ex- uh, it's an impulse. In case of hernia, it would be
It's in
expansive
hernia,
impulse.
sometimes in the laryngeal, sometimes in the empyema sense. So it means it is connecting into the cavity.
Yes.
It's a momentary increase in the size of the swelling, uh, or appearance of swelling during the act of straining or coughing. Word momentary is important. Momentarily increase in the size or appearance of the swelling during the act of straining. That's the exact definition. So word momentary is very important when you define the expansal impulse. It suggests that said the swelling is connecting into the deeper cavity. Understood? That is the point which it says actually. That's the meaning of that. Then of course pressure effects you have to look for. You know that, like I already told, peripheral pulse, edema, vascular disease changes, all those things. Palpation. This is the order you have to follow always. Remember, I'm not going to detail that. Read the book. Tenderness, size, shape, extent, edge, slip, erosion. Which swelling causes erosion? Karthik, which swelling causes erosion?
Sir.
Which swelling? Simple condition. Dermatocyst causes erosion. That's why always look
Erosion.
for erosion. That's why dermatocyst should be operated always under GA, especially in the skull. You need to do the CT scan. Surface, you have
Yes.
to always mention soft, firm, hard. If it is uniform
Yes.
or variable, you can't say soft to firm to hard. Which place it is soft, which place it is hard, which place is firm, you have to mention. So specifications are important. Plane of the swelling, fluctuation, translination, reducibility, expansal impulse on a cuffing, compressibility. What is compressibility?
Sir.
How will you define
On pressure,
compressibility? Keshav?
size is decreased.
On pressing,
Size
The
of the
swelling
swelling
get complete.
usually decreases.
get reduced, and
On removal, it returns back, sir.
it comes to its
No, sir. On
comes
like cough, it will be written, sir.
comes to its original size and shape. On
Yes.
pressing, swelling reduces in size partially, that word is important, partially, and on release, swelling comes back to its original size and shape. Both are important, original size
Yes.
and shape. Partially it get reduced. Now compressibility says that it is not connecting to the deeper cavity, but it says that only two conditions comes to your mind once it is compressible. What are the conditions? Which conditions comes to your mind? Two conditions. One is vascular malformations, like hemangioma, as vascular malformation. Second thing is lymphatic malformations. So if
Cystic
something
fibrosis.
is compressible, everything else is ruled out. You got only two conditions in mind: hemangiomas and vascular malformation, lymphatic malformations. Now, thrill is
Cystic
important.
fibrosis.
Understood? The thrill is important. Two types of thrills. What are they?
Fluid thrill.
No, no. Thrill of rapid flow. Give an example. Thrill of rapid flow. Thrill of rapid flow. In toxic thyroid, there is a thrill of rapid flow. Thrill of stenosis. Give an example.
Stenosis.
You see, no, in peripheral vascular disease, if femoral artery is stenosed, you will get a thrill and bruit. That is a thrill of stenosis. Thrill of blockage it is. Whereas thrill is what you feel in the thyroid is thrill of rapid flow. So there's a difference between
Yes.
thrill, even though thrill or thrill, there's a difference. Thrill of rapid flow, thrill of stenosis. Understood? Then part distal to proximal swelling, mobility. Also important. Extrinsic mobility, like moving with the deglutition, like that example, thyroid moves with the deglutition. There is the extrinsic mobility. Mobility, otherwise,
Aeroglossia.
intrinsic mobility is mobility in two directions. So there is the two types of mobility. Remember, extrinsic and intrinsic. Extrinsic example is thyroid moves with the nutrition. That is extrinsic one. As intrinsic is a mobility which you elicit. Okay, so these are the things which you have to remember. You have to remember the definitions of each component. There should be an order already told, and which is the methodology you present to write a case sheet properly. Percussion and relevant you have to, because there is, if there is swelling in the arm, you don't elicit percussion. But if there is swelling in the chest wall, you have to elicit percussion. Depending on the situation, you have to elicit auscultation of the same thing. Joint movement, especially in the limb. Adjacent joint movement, you have to always elicit. So you should know what are the joint movements, surgical, basic surgical anatomy of that. Measurement of the limb, measurement of the swelling. Always when you measure the swelling, vertical and transverse you have to measure. You have to use either measuring tape in centimeter or vernier caliper. Gait is important in the lower limb. And regional lymph node, you have mentioned, I think, lymph node not examined. I think Keshav has mentioned
Yes,
that.
sir.
Very, very relevant. Head and neck, axilla, in head and neck lymph nodes, upper limb and chest, axilla, both sides, and abdomen below the groin lymph nodes. Like that area, regional lymph nodes, very important. Relevant
Yes.
rhythms is the must in all patients: respiratory, cardiac, abdomen, skeletal system, spine, neurological system. And remember, special cases like already discussed: fluctuation, transformation, pulsatility, compressibility, reducibility, expansion impulse from coughing. Given the definition of each is very, very relevant in many, many situations. Remember, you should know the definitions, exact meaning, how to elicit, and what are the how to interpret is very important. Each test, how to interpret, and what is the outcome clinically probably. Next slide, Shreya. Summary of findings is analyze, correlate, conclude. It is the clinical entry. Analyze, correlate, conclude. Clinical diagnosis is
Yes.
diagnose congenital, traumatic, inflammatory, neoplastic. Anatomically, first thing, anatomically, what structure it's elicit from? Maybe skin, maybe supple tissue, maybe soft tissue, maybe fascia, muscle, bone. Pathologically, how will elicit consider? Surface, consistency, pain, tenderness. If it is hard, irregular surface, irregular, you think it is malignancy. If it is pain, tenderness, short duration, rise of temperature, probably is it abscess or inflammatory one. Long duration, chronic disease. 6 months duration with the hard swelling, provoking neoplastic, like that. All these things lead you into a pathological diagnosis. So your diagnosis should have anatomical component and pathological component. You said lipoma of the in front, lipoma left side scapular region. So anatomically scapular region. And pathologically, you said lipoma because lips line that is well localized. So these are the features you should club, correlate, and conclude and give a diagnosis. Key possible differential that is always don't be only one look. Always wider thinking is important for any swelling. Same thing, and evaluation is different clinical diagnosis, imaging. I said ultrasound, MRI, FNAC. Currently, true cut biopsy is a very good investigation. Systemic involvement, systemic assessment, metastatic assessment. If you think this is malignancy, of course, relevant blood investigation, including hemogram, tumor markers, and specialized investigation depending on the condition which you think of. Now, treatment option, excision, wide local exception if you are thinking malignancy. Depending on situation, again, local anesthesia, spinal, GA. So use your sense, use your discretion, what anesthesia you are going to do. Of course, further therapy, when this pregnancy, adjunct therapy is required, if it is infection, antibiotics required, depending on culture sensitivity. If you think tuberculosis, remember cold abscess is a common swelling. You would remember
Yes.
tuberculosis, cold abscess. So in such situation,
Hot
we
subs.
use the so follow-up also important. So
Yes.
not exactly next slide, Shreya. Well, just to go through it. Next. So this is a 1 year caliper tape. See how it does different spellings look. Next. Symplantation dermoid is a very common case kept in the exam. Adults bursa. So there is erosion. Erosion, external angular dermoid. How to do erosion? How to elicit erosion? It's large lipoma, very large lipoma. This requires general anesthesia to remove. This is the measuring how to. This is the dermoid cyst. Look at that punctum here. Sebaceous cyst. This is the typical
Yes.
implantation dermoid. Look at the adventitious bursa. Next slide. All these swellings are commonly kept a short case in your exam. That's why just showing this is a typical slip sign here. See, this hemangioma, you can see the bluish discoloration, typical hemangioma, where it is
Yes.
compressible.
Yes,
So
sir.
the neck secondary here, you can see that neck
Yes.
secondary. So lymph node is a very common mass swelling in the neck. You have to think of three conditions.
Yes.
What are they in the neck? Three
Sir,
conditions.
TB.
Lymph node. Secondary is lymphoma, tuberculosis. If you're able
Yes.
to
Yes.
for these three conditions, most of the time you are through. Any neck lymph node, commonest neck swelling is lymph node. After that, thyroid. Any lymph node, first three things you have to remember is secondary is lymphoma and tuberculosis. Remember, it's a pyogenic granuloma or skin adnexal tumor. See that it is a one Recklinghausen disease of neurofibromatosis. You can see the patch here. You can see
Yes.
multiple neurofibroma.
Yes, sir.
This one, this is the one probably turn into the neurofibrosarcoma. Remember, this neurofibroma can turn into sarcoma. Lipoma will not turn into sarcoma. Remember the difference. Okay, it's a large.
Okay, sir.
Probably it's a neurofibromatosis. One decline often disease of neurofibromatosis, which are turned into one of these things turned into neurofibrosarcoma. Look at this. That's how exactly it looks like. So look at other limb. Look at the patch, kephiolet spots. Next,
Yes.
yeah, next. So remember all these things. These are the whatever the photos I have shown. That the common short case kept as swelling. Other than hydrocele will be kept. So if you are able to read this swelling clearly, you'll be able to make it. You can go through my clinical surgery book, current edition. Got a video how to examine patient in detail is there. My manual surgery, all of you very well aware of that. Of course, operative surgery is a very big voluminous book. May not be for UGs. You can refer it mainly for PGs. My tissue approach small atlas to study it. Of course, my beginner lectures are there, which covers everything in detail,
Yes.
all subject for CBM, UG, everything.
Yes, sir.
So swelling examination is very, very important. Oxy they will keep, and many MCQs will come, and short case, definitely short case, remember. So common conditions, I have shown the photo, how exactly it looks like, sebaceous dermoid, and implantation dermoid,
Yes.
lipoma, then adventitious bursa, biogenic granuloma. I've shown most of this one, of course. You can go through my book, all photos, every condition photos are there for swelling, and definitely a
Yes.
long, short case, short note, and exam
Yes.
I will keep. And very commonly, interestingly, come across in the day-to-day surgical practice in surgery OP. So that is about exam swelling. Divya, over to you for any chat, any questions. We are exactly eight. We have finished exactly eight. Few minutes, just go to the chart. Any questions? Karthik or Keshav?
Yes, sir. One
Yeah.
so one question. Please repeat where the cross fluctuation is seen. One question from Pranav.
Okay. Pranav, cross fluctuation is across an anatomical barrier. It is not the standard fluctuation. I said already.
Mm.
Standard fluctuation in the two direction. Fix the thing.
Hmm.
Elicit in two direction according to Pascal's law. And that is across an anatomical barrier. Remember, whereas a cross fluctuation is across an anatomical barrier. One is plunging ranula probably. Second thing is iliopsoas abscess across inguinal ligament. Then
Yes.
compound palmar ganglion in the hand across flexor retinaculum. So the three conditions which we ranula plunging ranula is across mylohyoid muscle. You can feel a swelling in the oral cavity. You can feel the
Mm.
swelling in the submandibular region. So you can elicit fluctuation
Bilateral puncture.
across mylohyoid muscle. Whereas in the
Yes.
iliopsoas abscess across inguinal ligament. In compound palmar ganglion across flexor retinaculum. In the palm, there will be swelling. In the lower part of the forearm, there will be swelling. So their swelling, that's the cross. It's how exactly you will elicit cross fluctuation, swellings which are cross fluctuant in the usual MCQ question asked. And exam they will ask any swelling count, what is fluctuation when they ask, they will ask this one. So you should know how to elicit fluctuation. You should know cross fluctuation differs from standard fluctuation. And there is one more method called Page's test of the fluctuation in a small swelling. You fix the swelling, put to your finger over the summit, and you'll get the fluid movement, indent, you'll get yielding sensation. Fix it like this, uh, fix it like this, and put a small summit, and you will get yielding sensation, indenting or fluid movement, in a small swelling. That is called a Page's test of fluctuation. I think Karthik
Yes.
and Keshav should have heard about that. That's the
Yes,
one
sir.
maybe ask us a question, and in the exam they will ask you to elicit in Oxy. So that also you should know. So that's about fluctuation. So any other question, Divya?
Yes,
Karthik?
sir. One more question, sir. History, can we use fixed bony anatomical landmark to tell exact location of
Yeah.
swelling?
History?
In the history, yes, sir.
You can always convert like clavicle. If they say there is a swelling in the neck, above, how far above this clavicle, you can use it. You can convert into anatomical landmark in your own language. Patient will say from here, they'll show the collarbone. They won't tell it's clavicle. They don't know the anatomy. But you can convert into your language because you know the anatomy. You tell above the clavicle or in the neck, above the clavicle. You can definitely. Every detailed history in detailed anatomy you can't say. You can't say parts of the bone and then tell grossly that bone structure you can tell which bone you can always mention, no problem, it is should be, but not in detail about the bone, like tubercle of the bone, all those things you can't say. In the bone, tibia bone or collar bone, clavicle bone, lower part of the mandible, definitely grossly, not in detail. So any other question? I think this is the basic about the swelling examination. All undergrad should know as a general knowledge, essential knowledge probably in surgical side, and also when you face the exam in Oxy clinical case, they will keep and different questions will be asked. MCQs will come many in the swelling. So all those things. That's why swelling is very basic chapter for general surgery for UGs or anybody, including PGs. So I hope all students enjoyed and understood this one very well, Divya. Divya, next
Sir,
we'll
one more
discuss
one
about.
more question, sir, from the audience. How to identify sebaceous cyst without using skin pinching and absence of punctum?
Now, that is what you have give a diagnosis. You give a diagnosis without examining a swelling. It's not possible. That's a history only provisional. Final diagnosis you have to examine, and if there is skin pinching, not pinching has to be elicited to give a diagnosis. Of course, molding sign is there. That is again palpation. Molding sign is very typical, but molding sign is which is mainly elicited in the face. If there is a sebaceous cyst in the back, sebaceous cyst in the limbs, may not be able to elicit molding sign. Molding signs are very, very typical of sebaceous cyst because it shows that it contains pultaceous material. But that is more often elicited in the face, head and neck region, not in the back or other region where sebaceous cyst can occur. In the scrotum can occur, in the scalp then can occur. Scalp may not be able to elicit molding. All of you know what is molding signs, a very typical of sebaceous cyst. Probably that is the answer. If it has come as MCQ NEET exam, probably that is the answer. Molding sign without pinching the skin. But there is no claim. Nobody will give a diagnosis based on the one finding. There is nothing like that. It is a combined assessment of the patient. It is a correlation analysis. All findings should be useful, should be understood and give a diagnosis. One finding, one diagnosis is not a clinical system at all in surgical side. But still, if there is a question, probably molding sign is the answer. Otherwise, skin is not pinchable. It's the most important thing. Molding may or may not be there. Sputum again may or may not be there. So skin not pinchable is the very crucial thing, and mobile in both direction. It is a cutaneous condition in the subcutaneous plane. So plane is in the subcutaneous, but adherent to the skin. It's a very, very typical understanding of the pathology of the sebaceous cyst, which is very, very common exam case kept actually always excised most of the time excised under local anesthesia. But it can be multiple. It can recur if you don't remove the cyst capsule. That is the most important thing you have to remember. So Divya, this is probably
Yes, sir.
logically everything is understood about the selling. They can always go through my lectures, my book actually, basically clinical methods in detail and manual. And next probably is the Examination ulcer. This is also very important. Provisional date probably within 10 days. We'll announce in 2 days. And whoever interested, they're presenting, they can contact our team, Aditya and Shreya. Definitely, 2 people we want to present examination ulcer within next 10 days. The date will be announced within 2 days. Shreya, back to you. Divya, back to you.
Yes, sir. Thank you, sir. Your dedication to every student like us is truly commendable. Today, thank you for the lesson what we have learned today. So I would conclude today's session by once again I would like to thank Keshav and Karthik for good presentation and our team
They have presented
for
well.
good
Definitely,
technical support. Yes, sir.
audience wide outside and presenting because they real this one. They presented well. Karthik and Keshav really presented well. Good to keep it up. So hope I request all of you to subscribe my website and share it. Of course, it's a free, so don't require to spend some money from your pocket. But request is subscribe and share with all of your friends and colleagues, whoever you know, students in your college and across the country or other colleges. That's a request, Karthik and Keshav. And hope you'll join for our next live session also. I hope you join. You always go through my regular daily 3 to 5 minutes videos coming 6 p.m. daily. So
Yes.
any comments or any clarifications you can put in the comment. Definitely, it is very well
Yes, sir.
asset Keshav and Karthik. I appreciate both of you come forward to present the case. Really well done, Karthik and Keshav, and good luck to you for your exams, futures, everything. Thank you, Divya. Thank you, Shreya,
Thank
Aditya.
you, sir. Thank you.
Thank you, all audience, students all over the country, probably across my friends, doctors who have joined this session through YouTube. Once again, thank you, everybody. And thank you, whoever organized, my friends, Aditya and Shreya, organized this one very well. Thank you very much. Thank you, my one and all. Shreya, Aditya,
Yes, sir.
Yes,
we'll
sir. We
wind
are.
up. Thank you.
Yes, sir. Thank you, sir.
So, thank you, everybody. We'll wind up. Divya, we'll wind up. Thank you.
Thank you,
Yes,
sir.
sir.
Shreya,
Thank you, sir. Thank you.
for
Thank
the
you.
good support. Very well.
Good night,
Thank you.
everyone.
Night,
Thank you,
good
sir.
night
Thank
to
you for the
students.
opportunity, sir.
Examinations of ulcer. So date will be announced in 2 days. Karthik and Keshav, remember, we'll pick up somebody else. So please join everybody for that also. Thank you very much. Thank you. Thank you again. Good night. Study well, all students. Important. Reading is very important. Seeing is the patient important. Commitment is important. And it's very, very important. And seeing patient in the ward also important. So you can't skip those things in learning surgery. Okay. Thank you, everybody. Thank you very much. Thank you. We'll wind up. Thank you, Divya. Thank you, everyone. Thank you. Thank you.
Thank you for the opportunity, sir.
Thank you, sir.
Thank you, sir.